Ever wondered what happens when the very things keeping you alive, your red blood cells, start to, well, self-destruct?
Mm-hmm.
Imagine a rare condition where these crucial oxygen carriers, they just become targets.
Mm-hmm.
Leads to a whole cascade of
Yeah,
problems.
that's quite something.
That's the world of paroxysmal nocturnal hemoglobinuria, or PNH. Now, you've shared your revision notes with us, and our mission today on the deep dive is really to pull out the core understanding you need for, effective recall of this fascinating condition.
Absolutely, distill it down.
Exactly. We're going to look at what PNH actually is, what causes it, who might get it, the sort of intricate mechanisms behind it, what else it might look
Here's
like.
differentials, yeah.
Right. How common it is, how it shows up, diagnosis, management, the outlook, and potential complications. Okay, let's unpack this.
Great. So fundamentally, PNH is a rare blood disorder, and it's acquired. That's key. You're not born with it.
Acquired,
The
right.
main feature is this abnormal premature breakdown of red blood cells. That's the hemolysis we talk about. And a big clue, often, is hemoglobin turning up in the urine hemoglobinuria.
Ah.
Now, this all comes down to a mutation in a gene called PIGA. Think of this gene like the instructions for putting protective tags on your blood cells.
Okay, like little ID badges?
Sort of, yeah. And in PNH, this gene messes up, so you get a deficiency of these protective proteins.
Mm-hmm.
That leaves the red cells vulnerable to attack by part of the immune system called complement.
Right, the complement system.
Exactly. And this lack of protection, it doesn't just affect red cells, it also increases the risk of blood clots, thrombosis, often in quite large vessels.
So this PIG gene mutation, it's like a switch that gets flipped sometime during life.
That's a really good way to think about it, yeah. The etiology, the cause, is a somatic mutation. So acquired after you're conceived, specifically during hematopoiesis, that's the process in your bone marrow where blood cells get made.
Right.
It's definitely not inherited, not passed down in families.
Yeah.
This faulty PIGA gene basically disrupts the production of something called glycosylphosphatide delinocytol GPI-anchored proteins. Bit of a mouthful.
GPI anchors, let's call them that.
GPI anchors, perfect. Now imagine these anchors are like docking stations on the cell surface. They hold vital protective proteins in place. If the docking stations are faulty,
The proteins can't attach.
exactly, they can't attach properly.
And without these proteins properly docked, that's when the immune system gets involved.
Precisely. These GPI-anchored proteins, they normally display signals, kind of like don't attack me signs, to the complement system.
Okay.
When red blood cells lack these signals because of the PIG mutation, they become susceptible to complement-mediated hemolysis. The complement system basically thinks they're foreign or damaged and, well, destroys them.
Now, is there anything that makes someone more likely to get this PIG mutation? Any known triggers or risk factors?
That's the interesting thing. There aren't really specific established risk factors that clearly explain why some people get this mutation and others don't. It generally seems to pop up sporadically.
Just randomly.
Pretty much. However, we do see a potential link with other conditions where the bone marrow isn't working properly, particularly aplastic anemia.
Okay.
It's almost as if a stressed or unstable bone marrow environment just might, be a bit more prone to developing this particular genetic error.
Okay, so a random mutation can happen, maybe more likely if the bone marrow is already under stress. This leads to missing protectors, and then the immune system kind of goes rogue. Let's dive into the mechanics of how this unfolds, causes all the problems. Here's where it gets really interesting.
Right. The pathophysiology, it really hinges on those GPI anchors being platforms for crucial regulatory molecules. Think of two main proteins, CD55, also called DA, decay accelerating factor, and CD59.
CD55 and CD59, got it.
These act like off switches for different bits of the complement cascade, that chain reaction in the immune system. CD55 helps stop the early stages of complement activation on the cell surface.
Right.
And CD59 directly blocks the formation of the final killer blow, the membrane attack complex, which punches holes in the cell. In PNH, because those GPI anchors are deficient, CD55 and CD59 aren't properly displayed on the blood cells.
The off switches are missing.
Effectively, yeah.
Yeah.
Which means the complement cascade just barrels ahead unchecked. This leads to the lysis, the bursting of red blood cells. That's the intravascular hemolysis.
And that's what causes the hemoglobinuria, the dark urine.
Exactly that. When the red cells rupture, they release their contents, including free hemoglobin, straight into the bloodstream. The kidneys filter this out, it goes into the urine, giving it that dark, often reddish-brown color. You might notice it more in the morning simply because the urine is more concentrated overnight.
Makes sense.
And it's not just red cells. Platelets, the clotting cells, they also have GPI-anchored proteins like CD59. If they're deficient on platelets, the platelets can become sort of hyperactive,
Leading to clots.
increasing the tendency to form clots. Yes, that's a major complication in PNH. So this ongoing chronic hemolysis leads to anemia. The body just can't make red cells fast enough to replace those being destroyed, and that has knock-on effects throughout the body over time.
So if someone comes in with symptoms like, say, dark urine and feeling really tired, what other conditions would doctors need to think about before landing on PNH?
Good question. In the differential diagnosis, you absolutely have to consider other things that cause hemolytic anemia. Top of the list is often autoimmune hemolytic anemia, where the immune system attacks red cells for different reasons.
Okay.
Then you've got thrombotic microangiopathies like TTP, thrombocytopenic purpura, and HUS, hemolytic uremic syndrome. These involve clots and low platelets too.
So some overlap in symptoms.
Definitely some overlap, like anemia or kidney issues potentially, but the underlying mechanisms are totally different, and crucially, the treatments are different. So getting that accurate diagnosis is vital.
Right. A careful process of elimination then. Now, just how rare is PNH?
It is genuinely rare. Here in the UK, the estimate is somewhere around 1 to 10 cases per million people.
Wow.
It can show up at any age, affects all ethnicities, though we probably diagnose it most often in young adults. And like we said, it's not familial, not inherited.
In men versus women.
Pretty much equal frequency. There's maybe some slight suggestion it could be a tiny bit less rare in Southeast Asian communities, but honestly, more research is needed there.
Okay.
And the severity of the disease, how badly someone is affected, that often links back to the size of the abnormal clone of stem cells in the bone marrow.
Right.
Bigger clone, more affected blood cells, generally more severe disease.
Right. So how does PNH typically present? What are the sort of classic clinical features that should make someone think, could this be PNH?
Well, the clinical picture can be really varied, but there are definitely common signs and symptoms. That dark-colored urine, the haemoglobinuria, that's a real hallmark.
Right.
And here's a little memory tip. Think PNH, peeing nighttime hemoglobin, because as we said, it's often most noticeable first thing in the morning.
Peeing nighttime hemoglobin. Got it.
Patients are often really fatigued, weak. That's the chronic anemia. Shortness of breath, again, from the anemia. Not enough oxygen getting around.
That makes sense.
Abdominal pain is quite common, too. And then, unfortunately, those thrombotic events clots, like DVTs or PEs, can definitely occur.
And the complications.
Yeah, the potential complications are serious. Yeah. We worry about bone marrow failure, developing clots in unusual places like the liver veins. That's Budd-Chiari syndrome.
Ah, yes. So, quick question here. A young adult comes in with abdominal pain and cites fluid in the belly. PNH should be on the list because of the risk of which complication?
Budd-Chiari syndrome, exactly. That risk of hepatic vein thrombosis. Other complications include pulmonary hypertension, high blood pressure in the lungs, and kidney problems, renal dysfunction. The severity, as I said, it's a spectrum. From quite mild, maybe just occasional dark urine, to really life-threatening stuff with major clots or the bone marrow packing in.
And what might a doctor find on examination?
Well, you might see pallor, obviously, from the anemia. If there's an infection, maybe fever, purpura, those little purple spots. With Budd-Chiari, perhaps an enlarged liver, hepatomegaly, and that sites we mentioned.
Oh.
If there's a clot affecting the gut, the bowel sounds might be absent. Neurological signs could point towards a clot in the brain's veins. And sometimes, the less common, people get these odd, red, painful skin nodules.
Wow. Quite a range of possibilities.
Yeah.
So that paints a picture of a condition with potentially wide-ranging effects.
Mm-hmm.
How do clinicians actually confirm it? What are the crucial investigations?
The absolute gold standard for diagnosing PNH is a lab test called flow cytometry.
Flow cytometry.
Yes. It's super sensitive, and it can actually detect the absence or very low levels of those key GPI-anchored proteins we talked about, especially CD55 and CD59 right there on the surface of blood cells.
Okay.
Here's another memory tip. Flow so low, CD55 and 59 won't shine.
Nice. Flow so low, CD55 and 59 won't shine.
Exactly. Way back, they used something called the Haem's test, looking at whether red cells break down in acid, but flow cytometry is much, much better and more specific. That's the one we rely on now.
Okay, flow cytometry is key. What else supports the diagnosis?
Well, several general tests help build the picture. A simple urine dipstick will often show blood, meaning the haemoglobinuria.
Right.
A full blood count, the CBC, usually shows anemia, sometimes low white cells, leukopenia, and low platelets.
Okay.
Thrombocytopenia, too.
Okay.
LDH, lactate dehydrogenase, that enzyme released when cells get damaged. That's typically high because of all the hemolysis. And haptoglobin, the protein that mops up free hemoglobin, that'll be low or even undetectable.
Because it's all used up.
Exactly. It's busy binding all that hemoglobin floating around.
Yeah.
A bone marrow examination can also give clues. It might show the marrow working overtime to make red cells during hemolytic phases, or it might show reduced production if there's associated bone marrow failure. And another little specific finding, alkaline phosphatase levels in white blood cells are often low in PNH. But just to hammer it home, the key test is flow cytometry, looking specifically for that lack of CD59 and CD55.
Flow cytometry for CD59 and CD55. Got it.
And then, of course, if you suspect complications, imaging comes in. An MRI with contrast might be used for brain vein clots, venography for clots elsewhere, MRI, ultrasound, or special nuclear scans like a technetium colloid scan can check blood flow to the liver and spleen, crucial for looking for Budd-Chiari.
Okay, so we've got the diagnosis confirmed. What are the next steps? How is PNH managed?
Right, management. The main goals are pretty straightforward. Control the symptoms, prevent those nasty complications, and basically improve the patient's quality of life.
Makes sense.
We have a few main tools. Blood transfusions are often needed for the anemia and fatigue, ideally using leukocyte-depleted blood to reduce reactions.
Okay.
Anticoagulation blood thinners is really important for preventing and treating clots, especially if someone isn't on the more targeted PNH therapies.
Which brings us to
Eculizumab. This has been a really big deal in PNH treatment. It's a monoclonal antibody, and it specifically blocks the complement system at the C5 stage, which dramatically reduces the red cell destruction.
Wow.
Then, for some very select cases, a stem cell transplant, essentially a bone marrow transplant, might be an option. And one really crucial point. Patients, particularly those on eculizumab, absolutely need to be vaccinated against meningococcus, Neisseria meningitidis.
Why is that?
Because blocking that part of the complement system unfortunately makes them more vulnerable to that specific serious bacterial infection. So vaccination is non-negotiable.
Okay, eculizumab sounds like a game changer. Can you tell us a bit more about how it actually works?
Yeah, it really has transformed things for many. So eculizumab is what we call a humanized monoclonal antibody.
Right.
It's designed to bind very specifically to that C5 protein in the complement cascade.
Right, C5.
By binding to C5, it stops it from splitting and forming the membrane attack complex, that final lytic weapon. So it effectively puts the brakes on the intravascular hemolysis that defines PNH.
And the benefits?
Oh, they're significant. It helps stabilize hemoglobin levels, drastically cuts down the need for transfusions, reduces that awful fatigue, and generally gives people a much better quality of life.
That sounds amazing. Any downsides?
Well, the main things are that treatment usually needs to be lifelong, indefinite. And as I just stressed, that increased risk of meningococcal infection means rigorous vaccination and awareness are vital.
Right. Are there other medications?
Sometimes prednisolone, a steroid, can help reduce hemolysis in maybe about 70% of cases, but, long-term steroid use comes with its own set of problems, toxicity issues.
Okay, and anticoagulation, you mentioned that.
Yeah, it's key. For patients not on eculizumab, doctors might consider giving anticoagulants prophylactically just to lower the clot risk. And if someone does have an acute clot, they need immediate anticoagulation, often alongside starting eculizumab.
And the bone marrow transplant?
That's the potential cure for classic PNH, replacing the faulty marrow with healthy donor cells. But it's a major procedure, carries significant risks and toxicity, so it's really reserved for carefully chosen patients, often younger ones with severe disease who have a suitable donor.
Understood.
And one final point on eculizumab, it's very expensive. Plus, PNH is quite varied, heterogeneous, so it's not necessarily the right or accessible choice for every single patient.
So considering all these options and the variability, what's the typical long-term picture for someone with PNH? What's the prognosis like these days?
Yeah, the prognosis, it really does vary quite a bit. Depends on how severe the disease is when diagnosed, whether complications develop, and how well the person responds to treatment.
It's better than it used to be.
Oh, absolutely. The arrival of complement inhibitors like eculizumab has dramatically improved the outlook. Many people can now lead much more normal lives.
That's great news.
It is. However, complications like those blood clots, thrombotic events, and the risk of bone marrow failure, they can still definitely negatively impact long-term outcomes.
Okay.
An interesting thing is that in some people, the actual PNH clone, the abnormal cells, can sometimes shrink or even disappear over many, many years. But you can't predict that.
Right.
And unfortunately, even with better treatments, thromboembolism of blood clots remains a really significant cause of serious problems and, sadly, mortality in PNH.
And just to be crystal clear, can we quickly recap the main complications again?
Sure. Top of the list, as we've emphasized, are thrombotic events, DVTs, PEs, clots in unusual places like the liver or brain. These are common and a major cause of mortality.
Okay.
Then there's the risk of bone marrow failure leading to low counts of all blood cells, kidney impairment, renal dysfunction due to that chronic hemolysis.
Right.
Pulmonary hypertension can develop, and patients might be more susceptible to infections.
And the day-to-day impact.
Well, the ongoing hemolysis and chronic anemia just lead to that persistent fatigue, weakness, shortness of breath, all the symptoms that really impact daily life. That's why early diagnosis and getting onto effective management is so critical to try and prevent or at least manage these complications effectively.
So to sort of bring this all together, PNH is this rare acquired condition. Starts with a PIGA gene mutation, leads to missing protective proteins on red cells.
GPI-anchored proteins.
Right, GPI anchors. This leaves cells open to attack by the complement system, causing hemolysis, and also ups the risk of thrombosis.
You've got it.
We've covered the definition, the causes or lack of specific triggers, the nitty-gritty pathophysiology with CD55 and 59, what else it might be confused with, how common it is, the very clinical signs.
Including that memory tip, peeing nighttime hemoglobin.
Exactly. Diagnosis with flow cytometry, flow so low, CD55 and 59 won't shine. Management, especially eculizumab, the variable prognosis, and those significant complications. So what does this all mean for understanding this for revision?
I think it really underscores how crucial that link is between genetics, the immune system, specifically complement, and just maintaining the health of your blood cells, and what happens when that balance goes wrong.
Yeah. And here's a final thought to leave you with. Given that the PIGA mutation is acquired, something that happens during life, what research is going on now to figure out what might actually trigger it? And could we ever potentially prevent it in the future?
That's the big question, isn't it? Ongoing research is definitely looking into that.
Something to think about. For more revision resources and to really nail down your understanding of PNH, definitely check out pastthemsra.com and freemsra.com.
Great resources.
Thanks so much for joining us for this deep dive into paroxysmal nocturnal hemoglobinuria.